Without further ado, let's start. Let's head straight into it. So, I'm super excited to be here, and thank you so much for joining us. Good day to you, everyone, and welcome. This is, of course, the Transfusion Services 101 Masterclass for providers and caregivers, proudly brought to you by Lab2Doctors. I am Olayemi Takuro, and I am honored to be your host for today's session. And before we dive in, if this is your first time hearing about Lab2Doctors, or you're perhaps confused about what Lab2Doctors is all about, or you want to know more, Lab2Doctors, we have just one mission, and it is to redefine lab results accuracy. We empower clinicians, patients, and caregivers with precision and clarity in laboratory results. We're really invested and interested in supporting you to making informed decisions and of course, bringing out exceptional healthcare outcomes. And today's conversation, like I said earlier, is one that is really, really sensitive because it touches the heart of patient safety. Blood transfusion is one of the most life-saving interventions in modern medicine, and so it's very sensitive, and every step matters. And that's why we're gathered here today to talk about it, to upgrade our knowledge, and to reduce preventable errors in transfusion care. So whether you are a laboratory professional, you're a technologist, a phlebotomist, a caregiver, or a health staff supporting transfusion care or medical care, this masterclass was designed and taught about specifically for you. So over the next 1 hour, we are going to be exploring the foundational principles, critical steps, best practices, and all you need to know in blood transfusion. And of course, I am super delighted that we have with us our talented and amazing guest speakers here today. We have with us Dr. Caroline Furrh. Dr. Caroline is a doctorate-trained clinical laboratory scientist. She specializes in transfusion medicine, core lab operations, and regulatory compliance. Of course, she has led workflow improvement and advanced quality assurance to promote patient safety. She's focusing on education that empowers providers and laboratory professionals. And she's really interested in cardiovascular risk assessment, advanced lipid profiling, and expanding access to high quality diagnostics in undeserved communities. Ladies and gentlemen, please join me as we welcome Dr. Caroline Furrh. Thank you so much for joining us, Dr. Caroline. It's great to have you join us.
Thank you. Thank you. I'm glad to be here.
Okay. So, as you can see, we also have the founder of Lab2Doctors, a trailblazer, a woman that makes us happy when we see her come on, Dr. Chessie Voma, and she is a CLIA certified lab director, a clinical trial study coordinator, and the chief vision officer at Lab2Doctors. Dr. Voma has worked across high pressure environments from hospital labs to clinical trials. She develops and directs QA, QC, method validation, and regulatory processes. And she's particular about keeping away lab errors and protecting patient safety. We're so delighted to have you, Dr. Chessie Voma. Thank you so much for joining us today.
Thank you. It's my pleasure.
It's great to have you join us. Thank you, everyone, for being here. Just so we remember, once you join us, you can tell us your name and where you're joining us from. We really love to hear from you, and we're so happy that you can make out time to join us today. So, without further ado, we now hand it over to the presentation segment, and that is going to be done by our guest, our speaker today, which is Dr. Caroline Furrh. Hi, Dr. Furrh. How are you doing today? And tell us what you have for us.
I'm doing very well. I'm
Great.
going to go ahead and put my screen up for you guys to see. Let's see. All right. Can you guys see my title slide?
Yes, we can. And you can
Yes, we
drop,
can see.
okay, you can drop a comment in the chat box to just participate as well.
All right, perfect. Well, thank you again for having me. Thank you for the great introduction. I am Dr. Furrh. I spent 6 years of my professional life in transfusion service, so this is a topic very near and dear to my heart, so I'm excited to talk about it today. My goal is today to clarify some generally used transfusion medicine terms, explain the general blood bank testing workflow, and also answer commonly asked questions related to transfusion medicine, just to clear up some confusion and answer any additional questions you guys might have for me.
Thank you. And to continue with this, I would ask questions that are usually the burning questions that we have from the community for Dr. Furrh to answer and give you her insight on these questions. The first question, why does the blood bank request 2 samples? Why do the 2 samples have to be drawn at different times?
So I think that's a very important topic. Often when a patient gets a blood draw and then 10, 15 minutes later, we come back and, tell them we need to draw a second sample. Oftentimes that's perceived as a lab error or we missed something or forgot something, but that's not actually the case. So in the US, I know not all participants on this call are from the US, but in the US, the blood bank is required to type each patient without a historic record twice before we can even issue type-specific blood. And really, that is a safety measure just to ensure that the blood type obtained from the first sample we receive in the lab is indeed the patient who is going to receive the transfusion. At the same time, the 2 different draw times, that's another layer of safety measures just to ensure that the patient has been positively identified twice, and this just minimizes wrong blood and tube events. So really what's supposed to happen is either the phlebotomist or nurse or whoever will obtain the sample will go to the patient's room, make sure the patient matches the requisition, ask for name, date of birth, whatever other patient identifiers, draw the first sample, leave the room, come back and repeat the process. That is because ABO incompatible transfusions, so if there was a mix-up or patient ID error, can have very severe consequences. And it's not some hypothetical thing that, we say we want to safeguard against. It actually does happen multiple times a year in the US, and those reactions have severe consequences, sometimes even fatal. So we certainly want to prevent those.
Thank you. Very detailed response. Question number 2. Let's talk about type and screen and type and cross orders. What is the difference between type and screen and type and cross?
Yes, so a lot of times providers and ordering personnel think those 2 terms are interchangeable. They're not. I mean, they're very similar, but they're not the same. So a type and screen includes 2 tests. That's your primary blood type. That's the one we all know. That's either your A, B, O, and then the positive or negative behind it. The other thing this type and screen includes is an antibody screen. Now, this will just give us a general idea if the patient has developed any antibodies that could potentially react with donor red cells. It doesn't tell us what it is. It just tells us more of a yes or no if there are antibodies or not. That's the type and screen. Now, the type and cross goes one step further. For the type and cross, we perform the same 2 tests, but then we also actually physically walk over to the fridge, select the unit that is appropriate for the patient, take the unit of blood out of the fridge, print a tag, attach it to the tag, and let the provider know that this blood is ready and reserved for their patient.
Wonderful. Thank you so much. Then we're up to the next question. Dr. Furrh, why don't you just set up blood on every patient just in case it's needed?
Yes, so this again, just to stay on the type and screen versus type and cross topic, a lot of times, when you explain this to providers and ordering personnel, they go, well, why don't we just select blood for everybody? Why don't we type and cross everybody? And really, that's an inventory issue. So as I mentioned, with the type and cross, I go to the fridge, physically remove a unit of blood and put the patient's name on that unit. That unit is now reserved for that patient and will not be given to anybody else. Now, if I do that for every single patient, all of my open inventory will now be reserved and assigned for a specific patient and will no longer be in my inventory. So with that, that would prompt somebody, to go to the donor center and order more blood, saying, our reserves are empty. We don't have any unassigned blood. We need more. When in all reality, we're not anticipating transfusing all that blood, right? It's a just in case. And that just in case can become very expensive. So red cell units, even though they are procured from volunteer donors and have volunteer on the label, they're not free. Donors are not paid to donate their blood, but the processing and all the equipment and the additives that go into it, those do cost money. So it costs the hospital around $300 for just a regular old unit of blood. So if we keep ordering more and more to keep our inventory up because it looks like we're low just by reserving units, we're going to end up expiring units because we cannot transfuse all this blood and throwing all of that away. And that, again, will eventually increase healthcare costs, which is one thing we're all trying to safeguard against.
Wonderful. And just to add to the inventory realities, when we talk about the inventory deals with what is available, what rare blood types are there, and what is safe for the patient. That's the more reason why we make sure that we guard the inventory and not do cross typing for everybody, every patient. So we are now going to move on to the next question. What is a positive antibody screen? No, sorry. Let me, I skipped the other question. Give me a second. Why do type and screen and type and cross orders take so long to complete?
Yes, so that is the next question we get a lot, that we get phone calls saying, why is it taking so long? I need blood now. Can we expedite this process? So I just wanted to break down what all needs to be done to complete a type and screen. So first, after the sample is drawn and sent to the lab will receive the sample. This takes about 5 minutes. Just checking the sample for acceptability, making sure it's labeled correctly, making sure it's not hemolyzed, all of these things, and also accessioning it, basically assigning it a tracking number internal to the lab just so we can assign results to it, resulted in the computer system, all that good stuff. After that, the sample has to be centrifuged, so we need to separate the plasma from the red cells. And centrifugation is, a physical process. It takes time. It just needs to spin for 5 minutes. There is no way around that. Next is testing the sample, and this does indeed take 35 minutes at least. So a lot of people are under the perception that the lab is fully automated nowadays. Specifically for transfusion medicine, that is not the case. Most big hospital labs that provide advanced testing are still 90% manual testing. So there's actual people sitting there, actual clinical lab scientists performing the testing. And, that takes time. You have to set up the test, and that means you actually pick up glass test tubes, use Sharpie initials of the patient on there, you label it with what you're going to do. You take a pipette, you add drops of patient samples, drops of reagent. So it's manual labor, and there's no way to cut this short. Next, blood banking relies on immunological processes. We're waiting for an antibody floating around in either the patient's serum or the reagent to find antigens on red cells. And this, again, is a physical process. It takes time for those antibodies to find the antigens on the red cells, grab onto them, and form a reaction. And that time is called the incubation period. Again, if I cut that out, if I cut it short, I cannot guarantee you that I'm providing reliable lab results. So again, that step cannot be skipped. Next, you have to centrifuge the whole test system again so you can actually read it. Also not optional, unfortunately. And then lastly, an actual person, not a machine, will read the results, interpret it, so you can actually understand what they mean, and record the results, which takes about 5 minutes. So that brings a complete type and screen to about 45 minutes, give or take, and that's if everything works perfectly. However, if the antibody screen is positive, like I mentioned earlier, it doesn't tell you what is going on with the patient. It just tells you that you need to investigate further. So if you have a positive antibody screen, that will require additional testing, and that can often take hours. So also, if you perform the type and cross that we discussed earlier, as opposed to the type and screen, you have this additional step of walking to the fridge, selecting a unit and tagging it, which will add about 10 minutes to that.
Thank you. Yeah, when it comes to the blood bank, just so you know, the lab has about 9 departments. Not everybody in a lab works in the blood bank. We have specialized people who do this. We do cross training, but when it comes to the blood bank, there are people who are just there for the blood bank. So it's very important that you are aware of how much time and how manual the process is to ensure that we are releasing the right blood sample for transfusion. So this takes me on to the next question. Dr. Furrh, what is a positive antibody screen?
Okay, so if your antibody screen comes up positive, this is a very, very complicated process sometimes to figure out what it actually means. So the ABO and RH is the most widely known blood group system. Everybody basically knows it. That's just what we refer to as your blood type. However, every patient is typed for the ABO and RH antigens during routine workup. That's your blood type. But in addition to that, there are hundreds of antigens on the red cell surface that patients can make antibodies to. And for the antibody screen, the blood bank routinely screens for antibodies to an additional 27 antigens. And those are the most common and the ones that have the most severe implications for the patient. Really, in the future, there's a good chance that that antibody screen will be expanded to more than 27. So when the screen comes up positive, it just indicates that the patient has made an antibody to one or multiple antigens on the donor cells. And the blood bank now has to identify specifically what that antibody is to. And the reason it's so important to identify what it is because if I want to transfuse this patient, I have to find donor cells that lack that antigen that the recipient has made an antibody to, or else you're going to have a transfusion reaction, which can have severe consequences for the patient. So depending on the complexity of that workup and which antibody is identified during the course of this workup, it can take several hours. It is a very extensive process. Basically, we're going through the steps that we discussed for the antibody screen over and over, just with different cells, different combinations. It's kind of like a puzzle, which is why a lot of blood bankers like that job so much. But it just, you can imagine if you have to do that process 5, 6, 7 times over to get your final answer, it's very time consuming. And then also, after locating units that lack the antigen that the patient has made antibodies for, you have to cross-match that unit. And cross-match, people often don't know what it actually means, but it's an actual test. So for a cross-match, I take the donor red cells and I mix them with the patient plasma to observe for any agglutination or hemolysis. So cross-matching is very, very important because transfusing uncross-matched units to a patient with a positive antibody screen may result in potentially severe reactions, and it's strongly discouraged. So basically, we're trying to simulate what will happen to those donor cells once they are in the patient's body, and we'd rather figure out if something bad is going to happen in a little reaction tube on the bench, as opposed to giving blood to the patient and waiting to see what happens.
Thank you so much. As you all can see, there are antibody complexities and compatibility challenges that we face in the process of identifying the right blood donor sample for proper transfusion. This is a good example of some of the things that Lab2Doctors does, some of the things that you can visit us at Lab2Doctors. You can go to the website, reach out to us to ask questions. Whether you are a patient, a clinician, or a caregiver, we are all concerned about the well-being of each other. What does this result mean when it comes to future transfusions? They are now telling me that I have antibodies. If in the future I need another transfusion, is it going to affect it? You can reach out to Lab2Doctors, and somebody just like us, Dr. Furrh or another colleague or myself, would answer these questions. Or you could ask, how difficult is it to find a suitable blood product? Again, on Lab2Doctors platform, you can reach out, and this is not limited to the US. The platform is community facing, implying that wherever you are in the world, you can reach out to someone like Dr. Furrh or myself. Is this result something that the patient should mention during a doctor's visit? If you're visiting your doctor and you were told that you had some antibodies, should you be telling your doctor? You may want to come to Lab2Doctors platform to ask us. Or Lab2Doctors has, on the platform, we have lab medicine experts that are there to answer your questions, explain what your results are, what the results mean, and give you a detailed information on the next steps so that when you meet with your clinician, you are well informed on what to expect, what is going to happen with respect to the results. And so with this, we're going to move on to the next question for Dr. Furrh. What is the difference between uncross-matched and incompatible?
Yes, so those terms, often people think they're interchangeable. They're really not, and it is very important to understand the difference. Uncross-matched just refers to what we said earlier. It's usually used in time-sensitive emergencies. Typically, group O positive or O negative blood will be issued for immediate transfusion. But basically what it indicates is that the lab has not had enough time to perform that cross-match, the mixing of the patient's plasma with the donor red cell. So I cannot promise you that this blood will be compatible. I cannot tell you what is going to happen in the patient circulation because you have not given me enough time to perform the testing. So at least in the US, providers that want to transfuse uncross-matched blood, they have to sign a release form from the blood bank acknowledging that now the responsibility for any consequences lies with the provider. They have made that risk versus benefit assessment. Is it safer for the patient to receive uncross-matched blood because they might be actively bleeding out, or is the possibility of a transfusion reaction greater and more harmful than the situation they're currently in? So basically, it just shifts the responsibility. Usually the blood bank or transfusion services is responsible for providing suitable and the safest product for the patient. However, if you're not giving me the time to perform all of my testing, then I am shifting that responsibility to you, and you will have to sign that release form. Now, incompatible, on the other hand, as the blood bank has completed the patient workup, including the cross-match. So all of the testing is done. There's nothing else I can do. But in some instances, cross-matches appear to be incompatible. So we will see agglutination or hemolysis, and often that's due to drug or other testing interferences, certain medical conditions as well. But really, it has nothing to do with what the donor cell do with the patient plasma. It's just something we observe because of drugs or some other interference. Now, in this case, we will also ask the provider to sign a release form, but this time we will explain that we have performed all the testing. Yes, the product does look incompatible, but to the best of my scientific knowledge and reasoning, this product should be safe for the patient. I just cannot prove it objectively in a test tube because there are interferences.
Thank you. And when it comes to interferences, there are different types of interferences. And like she said, these interferences are biological, implying that it may be some medication you're taking. It may be just something that is in your system that is interfering. Now, this is beyond the limit of the lab to know what everything else that is in your system that would potentially interfere with the blood product that you're receiving. So this takes me to the next to let you know something else that Lab2Doctors can do. Again, if you are unsure about the medical terminology that you see in your lab results, or what consequences the procedures that you're going to go through would have on you as a patient, reach out to Lab2Doctors. We'll be happy to clarify and provide additional information, just like she's telling you about on cross-matched or incompatible. So you make intuitive decisions if you want it or not. Sometimes this can even be as complicated as people with different religious beliefs. They have different reasons why they cannot accept the samples. If you come to us, we would also give you the knowledge that you need. Maybe it's going to enable you weigh the risk or the benefits based on your religious beliefs to receive or not receive samples from other blood donors. So this takes us to the last and final question. Can you tell us about general blood type compatibilities?
Yes, and I think we've all, or most medical professionals have seen these charts. I still would like to go over it briefly. So there's really two sides to the story. One, we have to look at the red cells. So if a patient is group O and needs red blood cells, then they can only accept red cells that look exactly like their own and do not have any of the additional antigens. The O blood type is a lack of antigens. They neither have A nor O antigens on their red cells. So really, if you're a type O, then the only red cells you can receive is type O. However, if you're a type A, you do have the A antigen. So basically it's just a little sugar chain hanging off of your red cells. But if you have that one and your body recognizes that one, you can accept blood from donors that are also A or O, because O just means there's no antigens on there and that won't bother your body at all. Same concept with the B blood type. If you're type B, you can receive blood from donors that are also B or O. And then if you're AB and need red cells, you're the lucky one, because it literally does not matter what red cells they stick in you, you will be just fine. However, the other thing I wanted to mention is that these charts do not include the Rh positive or negative. It's generally, if you're Rh positive, it means you have the D antigen. If you're Rh negative, you're lacking the D antigen. So it's the same concept. If you're Rh positive, you can receive Rh negative products, no problem. If you're Rh negative, there is some leeway there, especially in emergency situations. It's generally regarded safe to receive Rh positive products. But if time and inventory allows you, you certainly should stick with Rh negative products. And if anybody's more interested in the emergency medicine and transfusion aspect, I'm happy to discuss that further if there are any questions. On the other side, you need to look at your plasma products, and that is everything that's yellow. That's the easiest way to recognize it. It's your platelets, your cryo, your plasma, anything that is not red. So if you're type O, you're the universal recipient for the plasma products, because you're already making the anti-A and anti-B antibodies, and those plasma products will also contain those antibodies, so that's not going to bother you. You can receive any plasma there is. However, if you're type A, that means your A red cells have the little A sugar chains on it, so you don't want any A antibodies in that plasma you're receiving. So you need to receive plasma from either a person that's type A, because they will also not make antibodies to the A sugar chain, or somebody who's type AB, because they also have the A antigen, so their plasma will not contain that antibody. And it's the same concept with the type B. And then type AB on the plasma side is not so lucky, because they can only receive plasma products from type AB donors. Again, in emergency medicine, there is some leeway. Type A plasma can also be given in emergency situations to any recipient. It can have some implications, again, if somebody's more interested in the emergency transfusion procedures, then I'm happy to discuss it further.
Okay, Dr. Caroline, I would like to chip into that emergency situation. When we're talking about blood transfusion now, is it possible that diseases can be passed through the blood if it's not properly screened, especially in emergency situations like you mentioned, if there's no adequate time to prepare or to screen the blood, is it possible that diseases could be passed to the person if the blood is not properly screened?
Can you repeat your question? I'm sorry, you cut out in the middle.
Okay, so can you hear me?
Yes.
Okay, so my question was, we're talking about blood transfusion, right? But we're not hitting on the dangers of blood transfusion. For example, you're mentioning the emergency screening. So I'm thinking, can diseases be passed through blood if it's not properly screened, especially in emergency situations like this?
Yes, I mean there's always, a risk benefit analysis. Like what is the greater danger to the patient? Getting a blood product that's possibly not 100% compatible, or is the risk of the patient bleeding out and not receiving that oxygenation and you know what's the greater risk? So there's always, providers have to make that assessment and sometimes even call the blood bank to see what our history on the patient is, if we can give further advice. But yes, that's certainly possible.
Okay, thank you for answering that. Dr. Chessie, now we're talking about the lab, right? So how does the lab handle cases of patients with antibodies, especially in a situation where they have multi-transfused patients?
So, um, before responding to this question, I was just going to add to the question you asked, Dr. Furrh, about transmitting diseases.
Yeah.
I want to say that here in the US, we have a list of um, transmissible diseases that we test in the lab. So there's no blood out there in the lab that has not been tested for this list of transfusion transmissible diseases within the US. I
Okay.
strictly say within the US because malaria, which is in Africa, is not in this list in
Mhm.
the US because it's
Okay.
not prevalent in the US, right? Since we have people globally on this webinar. So whatever blood sample is within the limits of the blood bank for the patient has already been tested and approved free of any any of these pathogens that are transmissible through transfusion. So I
Mhm.
just wanted to add to that. So yeah.
Okay.
Meanwhile, if there's anything that is not in the list, like I said, we have an exhaustive list in the US, and sometimes it's seasonal. There are things like chagas that it depends on the season. You would see a lot of it, and or you may not see a lot of it. There are also things like Epstein-Barr virus. Sometimes you see it because people have traveled from other countries into the US. So there's a screening criteria for those who donate blood. And if you meet the criteria, you're going to donate blood. But you could be somebody who just traveled out of the US and came back and you're donating blood. And so this you may have have this pathogen in your blood or not. But remember that we do test all of the samples before they are made available for testing, even within the blood bank unit.
Okay.
So can you ask your question again?
Yeah, so I was talking about in the case of the
So you
lab. How does the
yeah.
lab handle cases of patients with antibodies, and especially in cases where we have multi-transfused patients?
How does the lab handle? Can you ask it?
Patients with
It's breaking. I
antibodies.
can barely.
How does the lab handle cases of patients with antibodies?
Oh, with
Okay.
antibodies.
Yeah.
So once we identify the antibodies, so we basically have a bank of donor cells, we call them panels, that we know exactly what antigens are on those cells. We mix the patient plasma with those cells and then look for reactions. And that, gives us a certain pattern that usually lets us discern what antibodies the patient has made. So once I can give the antibody a name, I can now go to my inventory and find donor units that are lacking that antigen, that the patient plasma I know will not react with and agglutinate or hemolyze because that donor cell is lacking that antigen. Either those units are already labeled as missing a certain antigen by the donor center, or the blood bank has their own little chemicals, reagents, antisera to test the donor units and find an appropriate unit for the patient. And then once I have confirmed that the donor unit is lacking the antigen that my patient has made an antibody to, I still do the cross match, which we have explained earlier, is mixing the patient plasma with those donor red cells, just confirming one last time that there will not be any adverse reactions.
Okay, and to this, Dr. Caroline, is it possible to react badly to someone else's blood, even if it's mashed?
Yes, absolutely. There's always residual risk. Like I said, so our antibody panels typically screen for about 27 additional blood group antigens, just because those are the most common. But people do make antibodies to rare antigens that we usually do not detect during regular testing. And yes, absolutely, there can be a reaction. That's why every patient always has to sign a consent form that they have been educated on the potential risks before they're transfused. So it is possible, however, it is highly unlikely.
Okay, thank you for answering that question, Dr. Caroline. Dr. Chelsea, over to you.
Yeah, with this said, I'm going to use this opportunity to let you guys know how you can, instead of waiting for an event to occur before you're rushing to Lab2Doctors for help, my advice would be go to the website and create an account on the website. So fast forward when something happens, instead of going to Google, that you do not even know when they last updated that information, instead of going to up to date, that doesn't have real life information like we do, because we work in the lab, we live in the lab, we validate this test, we develop the test. So we have firsthand information and experience as to what is right. So I'm going to share my screen and walk you through the website for Lab2Doctors, so that you have an idea of what to do to create an account on the website and be able to. So once you go to lab2doctors.com, it brings you to this page.
Okay.
There's going to be a login. Let me see if I can go to the login real quick. Okay, wait. I just want to show you the login. Lab2Doctors. All right. So this is the home page. Once you come to the home page, when you log in, when you go to the website, this is what you're going to see. There's a sign up here. I hope you can see where my cursor, the cursor is moving. There's also the schedule now. Either you go to sign up, which is in red, top right corner, or schedule now in blue, bottom left corner. So I'm going to go to the sign up. When you go to sign up, this is my laptop, so okay, good. It has not done this again because my passwords are in here and normally it just logs me on. So if you come to sign up, you're either you have to enter your doctor's name. If there's no doctor, that is fine. You realize that there's no asterisk. That makes the information compulsory. So if you're signing up as a clinician, you enter this information. If you're not signing up as a clinician, let me roll my screen up. Okay. So you're going to enter this information whether you're a clinician or not. Okay, your sex and everything. Even the doctors also have an account on the platform because sometimes clinicians reach out to us to sign up with questions. So because I have an account, I'm going to log in. And when I click log in, it brings me to the screen. And I will log in as a patient today so that you see what you're going to see as a patient. So I click log in and it brings me here. So this is my patient account. And you're going to see this is a dashboard that tells you troubleshooting request. The questions you bring to Lab2Doctors will be here. Whatever you've asked us, the patient, the test, The status means, is it pending or have we responded? Have we given you a solution to it? And the date. There's also phlebotomy requests. Sometimes people are looking for someone to do the blood draw. Not just somebody to do the blood draw, but Dr. Voma, we are going to need help preparing this patient for blood draw for cardiac biomarkers. Let's say your doctor needs you to check is checking the status of your heart, and you eat every kind of thing, or you want us to just make sure that what you're eating is not going to interfere with your lab test. This is what we call phlebotomy requests. Either you need us to give you a phlebotomy who draws the blood, or you just need us to prepare you in advance so that those things that would interfere with the test and cause false negative or false positive results will be eliminated. So this is your dashboard, but that you'll be seeing. So this is under the troubleshooting request of phlebotomy request is going to show the doctor's name, the doctor that needed the blood work, and the date and everything. There's also something we call recurring lab orders. Especially this happens for people with diseases that are just managed, that are not treatable, like diabetes or hypertension, which are not treatable. These are what we call recurring lab orders. Because, for example, with diabetes, the doctor needs you to order an A1C test every 3 months. If you put this on the site, we are going to be able to reach out to you and tell you that your next A1C order is coming up and help prepare you for that, for the blood draw, so that we make sure that not even the tea or the herbs you drink in your kitchen would interfere with your lab results. So this is really what all of what we do at Lab2Doctors. You can, if you are on this platform as a clinician, I'm going to log out and try to log in as a clinician. So this login, again, you're going to see the same thing. But now what happens is that I've already enrolled in the system, so it's difficult for you to see that form. When you come to the system for the very first time, as a clinician, this is now to the doctors. And the patients also have this form. Whether you're a caregiver or a patient, there's a form that you fill for each encounter. What is on that form? We are not going to ask your social security number, any private information that would compromise your private, that would compromise you and put you at risk for people online. We do not ask that information. We ask your age, the test that you need to investigate, when you need to have the test done, what you have eaten, what you ate in advance of that test, that lab test, what you drank in advance of that lab test, when you slept before that lab test, because you know that there are analytes in your body that we test in the lab that have what we call circadian rhythm, implying that these analytes are higher at night and lower in the morning. What happens if you did not even sleep at night? You went out dancing all night and you have to do this test the next day. How is it going to affect you? It's important that you talk to somebody like us, because trust me, when you go to Google UpToDate or whatever those websites are, you are not going to get the information that we will tell you on Lab2Doctors. The platform is a community-facing platform, implying that we want to meet the community wherever you are. Wherever you are in the world, reach out to Lab2Doctors and we would take care of you. We would answer those questions, tell you those technical things that you would not know if you do not talk to us, because we know the different things that interfere with the lab test. We know what to tell you to avoid in advance of that draw. Otherwise, if you do not come to us and the lab test was done and you've gone to your clinician and the clinician is like, why? The result doesn't look realistic. Why is this result like this? I expected your potassium to be high, and now it's low. Your clinician is surprised, and you are surprised, and you don't know what is wrong, right? Because the clinicians are not pathologists. Pathologists stay in the lab. Clinicians see the patients, right? So we see your blood, and they see you, and the results that we've given. So there's this barrier. There's this gap between the lab and the clinician. The clinician is going to tell you, let's do another blood draw. If they've looked at every other thing and they don't know where else to look for, they'll tell you, let's do another blood draw. But can you imagine doing another blood draw and not eliminating that interference. If you spoke with us, we would have been able to say, do not use the green tea today. Maybe you should suspend that medicine or talk to your doctor about medicine because it interferes with this test. This is information that they do not have. We have it in the lab. But how many labs have more than 2 lab directors on board? And if all of you were to call my lab, in my lab, we test about more than 10,000 samples in a day.
Wow.
So if 1,000 people, let me even make it 200 or even 20, if 20 people called with issues and I'm the only director, who is going to talk to them, right? You're going to go to Google, right? And your doctor would go to Google too. And what if that information is not updated? Science is evolving and new tests are being developed. We are at the forefront of science and we are seeing what you will not see. It is the reason why I decided to create Lab2Doctors. We are the bridge between the lab and the doctor. Lab2Doctors is right in between. If you see my fingers, Lab2Doctors is in between. And that's why we call it Lab2Doctors. I hope I have made it clear to everybody. Subscribe on the site. You would see information that is released monthly and have an account so that when it happens, you know where to go to. Thank you.
Thank you so much for sharing, Dr. Chessie Voma, the founder of Lab2Doctors. Thank you for walking us through how to have an account on Lab2Doctors and ask questions. Okay, so we now have gotten to the question and answer segment, and we have a question in the comments box from Gilbert that says, "Thank you so much, Dr. Chessie and Dr. Furrh. This is important and enriching. I am an ASBT member, a certified blood donor recruiter, a VNRBD, and a hematology and blood transfusion science enthusiast. I would wish to know what can be done to mitigate the rate of transmission on TTIs, especially in sub-Saharan Africa and Cameroon, to be specific, where most screenings in the blood bank are done using RTD and can give false results and are also liable to the pre and post zone effects. Thanks." Okay. Dr. Caroline, do you want to answer this?
I believe Dr. Chessie is our expert here as she deals with the donor side of things.
Okay, Dr. Chessie, over to you.
So it says, I'm trying to read the question again, okay? I wish to know what can be done to mitigate the rate of transmission of TTIs. Please, there's a lot of acronyms. I don't want to assume. What is TTIs, please?
Okay.
You can text or you can say it.
Okay, Gilbert, if you're here, you can text what you mean or you can say it. Also, if you have any further questions to ask Dr. Caroline or Dr. Chessie, please leave them in the chat box. Okay, so I have a question. And my question.
So TTIs.
Okay.
Let's see. Okay, he has posted it.
Yeah.
Transfusion transmissible infections. Thank you. So it says the rate of transfusion transmissible infections, especially in sub-Saharan Africa and Cameroon, to be specific, where most screening in the blood bank are done using RDTs. Again, please, what is RDTs?
Okay, Gilbert.
You know these acronyms are not global. Let's see.
Okay, rapid diagnostic test.
Rapid diagnostic test. Okay, good. Thank you. So, so most of the test is done with this. I would say that I would like for you and your team to reach out to us. I'm saying so because there's a procedure that has been set in place. Sometimes the procedures meet the requirements or meet the demands of a certain population and not another. This may be due to financial constraints. I'm not aware. This may just be lack of knowledge. I'm not aware. So it would be nice to actually sit with your team to know what you do and why you do it. Is it because of insufficient finances or is it because of a lack of knowledge? Without which I don't want to, I may take a whole day to tell you what to do. But my advice would be to get an appointment with Lab2Doctors for us to sit with your lab and see how we can better help you. That's why we are there. That's what we are here for. Thank you.
Okay, thank you, Dr. Jesse, for giving that. Thank you, Gilbert, for asking the question. If you have a question, we have 6 more minutes, but before we end, we're still open to taking your questions. Okay, so coming from a patient and caregiver perspective, what are some of the things that a patient or caregiver should watch out for during the blood transfusion?
Okay, so one thing to definitely pay attention to, and I'm talking from a US hospital standpoint because that's where I have practiced, your unit should always be tagged appropriately. It should always be tagged with the recipient's name and patient identifiers, date of birth, all that good stuff. Also, if you know your own blood type and you have seen our compatibility chart, or you can even pull it up on the phone nowadays, I mean, you're welcome to check if the blood types are compatible. They really should be if you're in the US hospitals. There's many checks and balances before that blood product leaves the door. But the unit being appropriately tagged is the most important part to make sure the caregiver walked into the correct room with the correct unit and hung it for the correct patient. That's where most mistakes happen nowadays. The other thing would definitely be just to pay attention to your patient. Now, patients receiving blood products are often very sick, right? So it's just important to watch out for any change in status. If the patient is awake and oriented, if they're telling you 15 minutes into the transfusion, 30 minutes into the transfusion that they're itchy and hot or have a hard time breathing, any of those symptoms are definitely worth noting and bringing up to the nurse or the provider. Sometimes, it can just be a little bit of anxiety because people are nervous about receiving blood transfusions, but don't ever feel bad for bringing that to somebody's attention and wanting to investigate that. So really, any change in status, and the easiest thing to check and the most common culprit in mistransfusion is really your tag on the unit. Make sure it's for the patient it's supposed to be for.
Okay. Thank you, Dr. Caroline, for sharing. Dr. Chelsea, do you want to add to that?
I think she said it all. I think she said it all. Again, we are answering from the US perspective.
Yeah.
So if you are not in the US and and you've heard something that really sounds good that you are not doing in where you are, I recommend that you reach out to us, invite doctors, to your lab team, to your hospital team, for us to see how we can match the quality that we practice here in the US.
Okay. Thank you, Dr. Chelsea. And with that,
I
that
think
brings
that's the
us to...
question.
Okay, there's a question. All right. Any more questions? No, no more questions. Okay. So I guess that brings us to the end of our masterclass on blood transfusion services. And on behalf of Lab2Doctors, I want to extend a sincere thank you to our amazing speaker, Dr. Caroline and Dr. Chelsea, and to our audience from wherever you're joining us from. Thank you so much for joining this session. It was a very invaluable knowledge and practical session. And of course, I'm sure that a lot of people have learned today, caregivers, patients, lab personnel.
Sorry, I think she's having some network difficulties.
Okay, can you hear me now?
So yeah, we lost you. So
Oh,
anyway,
okay. Okay, so I said that brings us to the end of our Transfusion Service 101 Masterclass for today. And on behalf of Lab2Doctors, I would like to extend a sincere thank you to our amazing speaker, Dr. Caroline, Dr. Chelsea, and of course to everyone who made out time to join us for this invaluable, impactful session today. We're really grateful for that. And to our participants, thank you for your time, for your engagement and your curiosity. And remember that every step you take towards learning is a step towards safer transfusion and is a step towards better patient outcome. So thank you so much for joining us. Don't forget to stay connected with Lab2Doctors for more webinars, for resources and trainings that can help you and elevate your presence, your practice, and to keep you informed, of course. You can visit the website at www.lab2doctors.com to stay updated. And Dr. Chessie, do you want to add anything before we end?
Just going to say that if you're here in the US as a nurse, as a clinician, any grade of LPN to nurse practitioner to DNP, we provide this master 101 classes to your teams. So if you like what you've seen today, talk with your supervisor, invite us to your team, and we're going to tailor classes just for your team. If you're looking for continuing education courses, I think that having good lab knowledge is very important to be able to take care of your patients. So please do not hesitate to reach out to us if you think you like what you've seen today, or in the future there's some other lab topic that you would like for us to bring to your team. Let us know. We are going to post this. We normally post our videos on our YouTube channel. If you go to YouTube and look for Lab2Doctors, when this video is ready to go, we are going to post it on the channel. You can share it with your colleagues, share it with your co-workers, share it with your supervisors so that they know what we do. And if they would like something like this, we are going to do the same thing tailored to your team, whether it's ICU, whether it's the emergency department, whether it's outpatient care, whether it's oncology, whether it's dialysis. We will tailor it to your needs and bring it right to you, meet you where you are. Thank you.
Okay, thank you, Dr.
And that's
Chessie.
it for me.
Okay, Dr. Caroline, do you have any last thing to say?
Just thank you everybody for attending. And as Dr. Chessie said, I'm always happy to discuss transfusion medicine. So if you or your team have any interest, just reach out to us.
Okay, thank you, Dr. Caroline. And thank you everyone for joining. It's been an amazing session. And that's it from us at Lab2Doctors. Till the next time we have an amazing webinar or masterclass to bring to you. Thank you so much for joining. Have a lovely day ahead for wherever you're joining us from. And we'll see you next time. Bye.